I want to welcome you to the Infectious Disease and Global Health Emerging Pathogens Institute seminar. My name is Dr. Judith Aberg. I'm Chief of Infectious Disease for the Mount Sinai Health System and for the School of Medicine. And first and foremost, I want to acknowledge and thank everyone for just all the tremendous efforts going on at Sinai and through our community as we approach our practices and the science of coronavirus. I just want to make sure if anybody has respiratory symptoms, right, you know what to do. I was joking that we might have to cohort people, but if you do, please don't share. And so the main objective today of the seminar is to learn what we know about the virus itself, SARS-CoV-2, as well as understand the epidemiology, infection prevention practices, and potential future therapeutics for COVID-19. I'm going to use two phrases that you guys have been hearing a lot, NVCs, the more you know, and our Sinai experience, better together. So obviously, the more we all know, the more that we can all work better together to combat this infectious disease. We really need to stay calm and focused as we really how we think about our voice to the community and to one another. And we hope that today's lecture will not only enhance your own knowledge, but also be able to help you inform others about COVID-19. So without further ado, it's with great pleasure that I introduce our two speakers because we didn't want to further delay presentations. They both agreed it could be short on their introductions. So first we'll have Dr. Florian Krammer, Professor of Microbiology, a world-renowned virologist in the field of respiratory viruses and vaccinology, and Dr. Bernard Camins, Professor of Medicine, who is the Medical Director for the Mount Sinai Health System Infection Prevention. So please join me in welcoming our two speakers.
All right, thank you for the introduction. What I'm trying to do is I'm trying to give an overview that's not overly research-oriented because we have a very broad audience today. So let me start with a little bit of the history of what happened here. So on December 31st, 2019, China told the WHO that there is a few cases of pneumonia with unknown etiology that occurred in Wuhan. And actually they were clustered around the Wuhan or the Huanan seafood wholesale market, and that's what you can see here. It's not just a seafood market, they also sell wild animals, meat from wild animals. And so they didn't know what this was initially. And it turned out later, there was a paper in the New England Journal of Medicine that retrospectively they could also identify cases that were that got sick earlier. The first case here is actually from December 1st. What you see here is cases in red that have a connection to the seafood market and cases in blue that have no connection to the seafood market. So it seems that it had been going on for some time, but because there were very few cases, there was not really any alarm bells that were ringing. And then if you look at the timeline here, so it was reported. Let's see if we can minimize it. All right, better. Up.
You have your sound out. Can you make something that's feedback?
No, it happened earlier too. I don't know where the sound is coming from. All right. Anyway, so this was reported on December 31st, and the speed of science is really amazing right now. On January 10th, we knew what type of agent this was causing, and we knew the sequence of the virus. Fudan University in Shanghai sequenced the virus, and they released the genome by an Australian virologist, Eddie Holmes, and it was ready for download for everybody who wanted to get the genome. And what people saw right away, it was a coronavirus, a beta coronavirus. And it was named to the 2009 NCOV for new coronavirus because people couldn't settle on a final name initially. And so, hold on, what's a coronavirus, right? We talk a lot about influenza here. Let me tell you a little bit about coronaviruses. So coronaviruses are a huge family of viruses that infect animals and that infect humans. They're called corona because if you look at them under electron microscope, they look like a crown, right? Something that you would put on your head. And this is because of this spike protein on the surface, which is similar to the influenza virus hemagglutinin, but the coronaviruses, at least those coronaviruses, only have one spike proteins, and influenza has an AG and an NA. These viruses have a positive sense single-stranded RNA genome. They're pretty big for RNA viruses. They're actually the biggest RNA viruses. They're enveloped. You can see that here in the model. There's a lipid envelope, which is host cell derived. They're about 120 nanometers in diameter. And we're, we know these viruses. Actually, there's 4 human coronaviruses circulating every winter. Those include alpha coronaviruses like NL63 and 229E and HKU1 and OC43. And those viruses are actually responsible for about 30% of all common colds in the population. So, nothing out of the ordinary. There's also some more dangerous ones, and those are also beta coronaviruses, and this is SARS coronavirus from 2002-2004. This virus was eradicated from the human population. And then we have the Middle Eastern respiratory syndrome coronavirus, which is transmitted from camels to humans in the Middle East, but it doesn't seem that it easily spreads from human to human. And so the new virus got actually 2 names, or not the virus, but the disease. The first name that came out was from the WHO, and that was the name for the disease, and that's called COVID-19, and that means Coronavirus Disease 2019. For the virus itself, it was a little bit more complicated. If you look at the phylogenetic tree on the left side here, these are alpha coronaviruses. Here we have beta coronaviruses. And the new virus actually clusters very well with SARS coronavirus from 2003, but also with a lot of these SARS-related viruses that people have found in bats. And so the ICTV, which is the authority that names viruses, called it now SARS coronavirus 2. What do we know about the virus? As I said, science was really moving very fast. There was a first paper that was already published on the January 20th, or basically put on bioRxiv on January 20th. They came out of Wuhan Institute of Virology, so directly from where the outbreak happened. And they already showed that they could isolate the virus. So this is a virus growing on vero cells here. They visualized the virus with electron microscopy. They already looked at the immune response, so we know that humans make a good immune response against the virus. You see the typical IgM response first, followed by an IgG response. The response also seems to be neutralizing. That was corroborated by later papers. And they also looked at the sampling sites and where they can find the viruses. They established a qPCR to actually look for the virus in the patients. And what they found was that you find it in the lung, in the bulb. You can also find it in oral swabs. But it's relatively hard to find it in nasal washes. So it seems to go deeper into the lung. It doesn't like the upper respiratory tract so much. Scientists also solved relatively quickly how the virus enters cells. So it's using the same receptor that the SARS virus from 2003 is using, or NL63, which is one of the coronaviruses that causes common cold. And there were 2 papers that came out very quickly. One from the Rocky Mountain Labs, which is part of the NIH. And the first author here might be known to some of you, Michael Letko, is a trainee from Viviana Simon's lab. So they published this very, very quickly. It became clear that it's the same receptor that is used, and that makes sense with the lower respiratory tract infections because that's where ACE2 is expressed. The next milestone was from Jason McLellan's lab together with the VRC. And they actually got a structure by cryo-electron microscopy of the spike protein within a few days. And they could also show that it's binding to human ACE2. Going back to the timeline in China, so I told you that we had a few cases already in December. This is shown here. What this timeline shows is actually cases per day. We have two different data sets here. One is by date of onset, and these are these gray or bluish bars, and then by date of diagnosis, which are these yellow bars. And you can see that the case numbers per day went up really quickly, and China reacted relatively fast to that. So on January 23rd, so the first death was reported on January 9th, and on January 23rd, they locked down the complete city of Wuhan. The next day, they locked down the province in which Wuhan is located, and that's Hubei, and then they started to lock down other cities as well. And as you can see here, this worked. The case numbers went down. And China currently is reporting approximately 100 new cases per day. There's more deaths because that's kind of the tail end of that wave. But it seems like they got that under control. This is just the cumulative case numbers. So we ended up to have about 80,000 cases. You can see initially there's a lot of cases that don't have an outcome. Then people start to recover and get released from the hospital. In red here you have mortality, but you see that a large proportion of the people actually recover and get released from the hospital. There's this interesting jump here. That's when China changed their case definition from basically having to detect the virus to just look at the CT scan or an X-ray to see the lung pathology. And you also see that the line is becoming very flat here. So there doesn't seem to be a lot of new cases. I'm not going to go into this lockdown situation. It basically told people not to leave their apartments anymore. They were not allowed to leave the cities anymore, so they just stayed at home. But I wanted to show you this picture because it really shows you that China pulled the plug out of the country. What you see on the left side, these are images from NASA. Are emissions for NO2, which basically indicate industrial activities. And this is from January 1st to 20th. And this is after the lockdown from February 10th to 25th. So I think it's good for the environment, but it's massive. It's a massive scale. They really pulled the plug out of the country. Everybody was at home. And so today they announced that they will start to have people go back to work again, except for Beijing and for Hubei province. So we'll see how that works out in the next couple of days. And so just to show you, let's see if this works. Yeah. So this is just how this develops. So you see the date here. We have cases in China, very few initially. And then obviously you have exports, right? People who are traveling. Then you have a massive increase that starts in China. Cases were detected all over the globe. And what you then see pop up is specific countries. Will come soon, about mid-February. You start to see Japan is coming up. Korea is coming up, and then Italy was coming up. That was a big surprise. And then you see Iran coming up. So that's kind of how the situation developed over time. So this goes until the end of February. So now how do we go back here? Oh yeah, great. And so there's outside of China, there's 4 countries that you have to watch. Because they're important for this outbreak right now. One is Japan. Japan doesn't actually report that many cases or deaths, but the cases that they report are from weird areas, from rural areas. There's just cases popping up, which basically means that there's transmission, but they don't really see where the virus goes. There's community transmission. South Korea is very interesting. They have the 2nd highest case number right now, but they test like crazy. They tested 110,000 people. So they basically detect asymptomatic cases, mild cases. They have the best numbers right now. So this is something to look at, and we'll get back to that. The next point is Italy. The next country is Italy. And Italy, they only detected the outbreak because there were 1 or 2 severe cases. And they started to test widely. But in a way, it was kind of too late because a lot of people from Italy or infections from Italy had seeded outbreaks all over Europe. So there's now some level, low level of community transmission in Spain, France, and Germany and other countries in that area. And the Italians are trying to control this situation in their country right now. The worst was Iran. The first cases that were reported were already deaths. So they didn't see it, it was flying under the radar. And Iran is actually interesting because a lot of the senior leadership in Iran got infected. The vice president is infected, and 2 politicians, pretty high up politicians, died of it. So they don't have reliable numbers. That's the problem. They don't have an idea of how big their outbreak is. And this is reflected in this graph, which shows cases onset per day outside of China. And so you have, this is driven basically by 3 countries. And those 3 countries are basically Europe, which is Italy, Eastern Mediterranean, which is Iran. Iran also seeded a lot of cases in the Middle East. And then this is basically Western Pacific, which means Korea. How does it look in the US? Much, much better. You see high case numbers right now. A lot of these case numbers include the people that were evacuated from this cruise ship and from Wuhan. And they are mostly sitting in Texas, Nebraska, and then in California. We're also not very worried about what is called here imports of limited local transmission. So these are cases that came in from a country where there was widespread transmission and got sick here. And if I say local transmission, I mean basically they transmitted the virus to people very close to them. So you can follow this transmission chains. And that's what happens in most of the country, most of the states. It's a little bit different. In Florida, they had cases where they couldn't trace it. There's also 2 cases in Illinois where this was not possible. We have now a question mark about the case from Colombia yesterday. It's not clear if that was acquired in New York or if that was an import from Miami. And then you have very limited community transmission in California and Oregon, but there's something going on in Washington State. There's 9 deaths reported in the US right now, and they're all from Washington State. And I wanted to explain why that is. So remember the first case that was detected in the United States was actually in Seattle, right? Or a little bit outside of Seattle, and that's what we call Washington 1. And so this guy is here. And now this outbreak started in Washington State, mainly in a nursing home. It got detected when people were already dying there. And so Trevor Bedford was in Seattle, and he was part of the Seattle flu study that actually Bill Gates funds, not the Gates Foundation, but he himself. They isolated one of the viruses from these new cases and sequenced it. And what he was showing is that this virus, which is called Washington 2, is actually related to Washington 1. So the hypothesis now is that the first guy that came in infected maybe somebody on the plane or in the hotel or when he was walking around before he was feeling sick. And that's why we see now deaths there, because there has been transmission ongoing under the radar, probably a lot of mild cases, and until it reached the nursing home, and now we see deaths. So that's the explanation here. There's a lot of numbers out there that I wanted to explain. The first question is how infectious is this virus? And to measure infectiousness, in a way we use what's called R0, or the reproductive number. You have to take that with a grain of salt because it really depends on the situation and the environment. But basically what it tells you is how many people an infected person infects. For Ebola, that's about 2. Measles is really scary, that's 11 to 18. That's very infectious. Influenza virus is usually between 1.5 and 2. And for the SARS coronavirus, the assumption is 2 to 3. Right now in China, the reproductive number is much lower because obviously they had good countermeasures, and the countermeasures reduced the R0. And then there are speculations about attack rates. There's no really good numbers, but people assume right now it's about 30%, and that's coming from estimates for different influenza pandemics. But again, there's no good number out there. If somebody tells you they have an attack rate, tell them you don't. In terms of symptoms, I'm just covering this very, very briefly. It doesn't look like the common cold. So the majority, I think 80% of cases, have fever, dry cough, and fatigue, but they usually don't have any kind of sniffles and no nasal congestion. That's relatively rare. So that again goes with the tropism and the receptor expression for the virus. Many of the cases are really mild disease, and there might be many more asymptomatic cases. That's important to keep in mind. We'll go a little bit more into that. About 15% of the cases are severe or seem to be severe, and I'm saying cases, I'm not saying infections. And 5% are critical cases, and that's backed by numbers from China and partially also by numbers from Italy and Korea. Who gets infected? This is from a study that the Chinese CDC published. It's based on 44,000 confirmed cases in China. And they split it up here in Wuhan, then the whole Hubei province in China. We can just look at the China numbers here. So they have this 10-year age bracket. And what you see is basically that the whole population can get infected. So it's not like the virus would prefer to replicate in old people or in young people. There's a lot of people in this age bracket in China, and so a lot of them get infected. So that's kind of the distribution. I want to go a little bit also in the case fatality rates, specifically because you see some scary numbers out there, especially the case fatality rate that the WHO is now using. So there's 3 different rates that are in a way interesting. There's the closed case fatality rate, which is the least interesting and the most scary. That's right now at 6%. That's kind of the number of deaths divided by the number of recovered people. It's a very weak number, because a lot of mild cases are not reported. A lot of mild cases recover, but nobody keeps track. And so this number has been going down in China from 20% to now 6%, and it's going to fall. The case fatality rate is the numbers of deaths divided by the number of cases. And again, you have to take that with a lot of, not just a grain of salt, but maybe a spoon of salt. It's very likely a high overestimate. Not all cases are captured, and there's other factors, and I'll explain that in a minute. What we really would like to know is the infection fatality rate, but in an outbreak scenario, you won't get that data, and you establish it after the fact with serology. We're actually working on an assay right now to be able to do that. So in terms of the case fatality rate and explaining the numbers a little bit, you have to take into account how many people are tested and how many people who actually got infected you catch in a country. And I mentioned South Korea earlier, which is here. And so they have tested about 110,000 people. They trace all contacts. They basically test everybody. They even retest people that test negative just to make sure. And then in the United States, and that contributes to our case fatality rate right now, there were only 472 tests done. And this is of March 1st. The CDC stopped reporting of how many tests they're actually doing. There's other countries like the UK, for example, that also test widely, and Italy has to now, but I think they are still underreporting cases because they don't have that high of a testing capacity. But this is important to keep in mind when you look at case fatality rates. So remember, the WHO said 3.4%. But there's many factors that go in there. So the first factor is how many cases of all cases are detected. How good is your healthcare system? And in Wuhan, obviously, the healthcare system basically broke down just because there were so many cases and the hospital capacity wasn't there. And the other important point is for how long has the outbreak been ongoing? Because it takes a while for people to actually die of this disease. And so you have to wait for a few weeks until you get reliable numbers. But what I wanted to compare here, 3 different countries actually. First of all, China, and that China is really driving the number that the WHO is using. And then the US. If you would just do a crude calculation of the case fatality rate now, it would look terrible. But you have to look at countries where it's very controlled. And that's South Korea, for example. These are the cases from yesterday. Their case fatality rate is falling the longer we go into the outbreak. It's actually today's lower than yesterday. What you see there is that if you test a lot and if you catch a lot of cases, the rate is about 0.7. That's still not the true case fatality or the true infection fatality rate, which is probably much lower, but it's a much better estimate. And that's also corroborated by this country here, the Diamond Princess, which was an interesting scientific experiment that kind of went wrong ethically. So there was this cruise ship that had cases, and the Japanese government decided to keep the people on the cruise ship because they thought they could contain the outbreak, which was not the case because the virus actually infected 706 people on that cruise ship, I think, which is about 10 or 20% of the people who were on the cruise ship. And also, as of far, 6 have died. So that gives you a case fatality rate of 0.8. That's also skewed because typically young people don't go on cruise ships, and I will show you in a minute why that matters. But that gives you a more realistic number because they really started to test everybody. There were a lot of mild or asymptomatic cases, even in the older population there. And in contrast to that, we have the US, again, where the number appears to be very high, but is completely wrong. And this is also from this 44,000 K report from China. What they looked at here is case fatality rates per age, right? And so those are important numbers. Don't focus so much on the actual numbers. They might change, and they're changing already in Korea. Focus on the distribution. I think that's the most important part. First of all, below the age of 10, nobody died. There was one case basically in the age group 10 to 19, and then you see that the case fatality rate until, I would say, 50 is relatively low. And then it starts to climb up. The most vulnerable seem to be people who are above 80, but I would also say that the 70 to 80 range is problematic. And in this report, they had a case fatality rate of 2.3%. There's also something interesting going on between females who had a lower case fatality rate and males who had a higher case fatality rate. Once again, proving that actually males are the weaker sex. What you have to be careful clinically is also people with comorbidities, hypertension, diabetes, cardiovascular disease, chronic respiratory disease, and cancer had case fatality rates that were higher, between 5 and 10%. So you have to be careful if you have patients that have these comorbidities. What you also have to think about is that a lot of these people stayed in the hospital for a long time. So this is not a virus that causes rapid disease and you die from it. People who really die from it usually die after a long time in the hospital. That's also something you have to keep in mind for planning. I looked at the Korean numbers this morning. They match in terms of the patterns. They see the same age distribution. They see the same sex distribution, but the case fatality rate is basically half or lower than what we see here. So again, if you have good numbers, it tells you that actually the case fatality rates are much lower. And I have 2 more slides about things that we can do as countermeasures. One is therapeutics, and we're really lucky there in a way. There's now clinical trials for 3 different therapeutics in progress. 3 of them, or 3 types of drugs are tested in China. 2 of them, I believe, in the US. The first one is remdesivir, that's produced by Gilead. It's a nucleoside analog, broad-spectrum antiviral. It works very well in non-human primates against MERS coronavirus, which is related. It's effective against many coronaviruses. It works against the old SARS virus, bad SARS-like viruses. And the good thing is it has been tested in phase 1 already for Ebola. It didn't work out that well for Ebola, but there was a trial that compared it to monoclonal antibodies that were neutralizing. That gives us the safety data that you need to move this forward quickly. And there's trials now in China, and there's trials at the NIH, and they are saying that they will have results probably by April. There's also ritonavir, which is a mix of 2 protease inhibitors that were developed for HIV. They are marketed by AbbVie as Kaletra and Aluvia. And so they are licensed, they are on the market, which is even better. They have been used compassionately for SARS in 2003, There was no real clinical trial. They just used it and then compared that to data with untreated patients that they had, but there was no clinical trial set up. So we don't really have an idea if this works well, but it does work well against the MERS coronavirus in primates. That's another indication that those might be good drugs to use. What we don't know is when they need to be given, if they would help in severe cases, in critical ill cases, so the clinical trials will tell us. A few days ago, Arturo Casadeval from Johns Hopkins wrote an editorial in the Wall Street Journal about using convalescent serum that has been used in the past for Ebola, for measles, and so on and so forth. And so the Chinese started to do that. There's now a formal clinical trial going on, but there's already anecdotal evidence from China that it seems to work. So they started to do that 3 or 4 weeks ago, and that might be successful as well. Vaccines will take a little bit longer. Made this graph with one of my students, Fatima Amanat, just to show what people are doing. There have been vaccines developed to certain stages for MERS and also for the SARS virus from 2003. 2 of the SARS vaccines actually made it into clinical trials, but only phase 1 and were never further developed. But it's very clear what the target is here. And the target is the spike protein on the surface of the virus. And if you get antibodies against the spike protein, specifically the receptor binding domain, you can neutralize the virus. And so where we are right now is a lot of biotech companies started to make vaccines. There was a lot of funding put into biotech companies by CEPI, but now also by other agencies. And there's many different vaccine types that are in development, including RNA vaccines, DNA vaccines, recombinant protein vaccines. Actually, the Sanofi factory in Pearl River, just across the Hudson, is gearing up to produce recombinant spike protein in the process that they usually use to make flu block. We have vectored vaccines, and then there's also ideas about inactivated and live attenuated vaccines. All of them are still preclinical, except the mRNA vaccine. They haven't started to use it in patients yet, but there's already a clinical trial registered, and that's a collaboration between Moderna and the Vaccine Research Center at the NIH. Just a word of caution, you read these press releases about vaccines and that they're getting ready and so on and so forth. They're getting ready for phase 1 trials, and Tony Fauci has several times stressed on national TV that it will take about a year to get a vaccine, and that's very realistic. The reason for that is we have to go through all these phases. There's no coronavirus vaccine on the market. There's nothing we can model this after. It's not like flu where you can do a strain change and then get the vaccine faster with existing technology. So basically the processes have to be developed. Clinical testing needs to be done, which might be shortened. We might not go for the regular phase 1, 2, 3 trial format, but it needs to be done. The vaccines need to be licensed. There needs to be production capacity. They need to be administered, and only then you can basically develop an immune response. So the vaccines will come, and if this really starts or keeps circulating in humans, the vaccines might be very useful against this virus if it becomes a seasonal virus. I just wanted to mention a number of resources. If you want to look up case numbers or if you want to get information. For information in terms of preparedness, the CDC homepage is really good. They haven't been keeping up the numbers, so you don't find any actual case numbers there right now. The same is true for New York State and New York City. They're very slow with updating numbers. So they still say, as of this morning, that there's only 1 case in New York. What I've been following, and that's kind of trashy online platforms that work out very well right now. There's one that's called Breaking News Online and another that's Worldometers. And they have very good editors that seem to basically find cases in the media and then basically find a good source, either state or kind of national labs that confirm that, and then have a list of the cases. So they're really good. If you go to these web pages, it will give you a reference for the cases that they see. And so with that, I just wanted to thank my team. There's a lot of people in the micro department who are working on these viruses right now. We have been gearing up for a long time now to actually make reagents that we are sharing widely. we are developing ELISAs to do zero studies. And the person who really took the lead in my lab is Fatima Amanat, who's now making, I'm actually not sure if she's here, she's making hundreds of milligrams of the SARS spike protein, and we are distributing that to a lot of labs who are working with that. And so that's my last slide. I don't know if I should take questions now.
Okay, thank you. Florian, it's really an honor to share the stage with you, considering that you're a world-renowned expert on, and so I think we are good, because I have same slides, and so I'll skip some. Okay, so I have no conflicts of interest to disclose for this talk. The only disclaimer I have is that whatever I say now may change this afternoon or tomorrow, right? So again, and I think with all the media coverage on this, I think everybody in this room probably is already a novel coronavirus expert, right? So I'm going to skip that. Just show you. Someone made a comment to me, a layperson said it may be easier to show countries that are not affected versus countries that are affected. And again, I think just last week when I had the slide, Diamond Princess was actually #2 as a country, right? But now they're down. And the only comment I have about that is that it was a failed experiment, but I think one of the things that I know is that the food was still prepared on the people who were quarantined and the boat or on the ship by the same workers who were also infected. So when you have an infected potentially, is one of the things that they didn't do was actually that they didn't have food delivered in potentially. So that could have been the reason why. But there are other things too, that they are all in close quarters, right? If anyone has been on a cruise ship, especially the staff are really crowded, right? So potentially, anyway. But again, it probably is not something that we should do because it's really crowded and that people are in close proximity. Considering if you have to stay away 6 feet away from people, it's really hard on a cruise ship to do that. This is again just to show you the number of states that are now reporting cases. And as Florian said, unfortunately, New York State, this probably needs to be updated based on today, right? But certainly, at least the last time, as of yesterday, they're saying that they tested 41 people with only 2 positives. But again, that already changed today. So I think just to point out that from the very beginning, there was actually evidence that there was person-to-person transmission, right? Because if you see the blue bars here, that these are patients who were confirmed to have COVID-19 who did not have any exposure to the Hunan seafood market. And even from the very beginning that there were people who weren't exposed. And so there was definitely person-to-person transmission. And I found that this is the best, at least clinical data available right now. This was from Zhongnan Hospital in Wuhan, where they had, these are the first 138 clinical cases or confirmed cases. The interesting thing here is that, again, based on the previously mentioned, is that people who are older tend to be in ICU, so who are sicker. One thing that I wanted to point out that unfortunately there were 40 cases in the medical staff, and at that time they didn't know that they had an outbreak. So that's really understandable. They didn't implement their infection prevention practices. They didn't have the proper PPE at that time, and so a lot of healthcare workers actually got infected, including also hospitalized patients already. So 12% of their cases out of 138 were patients who were hospitalized for other reasons, right? So that's important to know. And then as far as comorbidities, again, the difference is that people who had comorbidities were more likely to be admitted to the ICU, and so were sicker and potentially were intubated. And again, these are cases who were admitted to the hospital, so you have to really, 98.6 of the cases had fever, but that's for people who are admitted, so these would be sicker patients. There would be a lot of patients out there who are not, who may not be symptomatic. Again, a lot of them also reported fatigue, having a dry cough, myalgia, dyspnea, sore throat as well was reported. 10% of them had diarrhea, which I think is important because with SARS, there were a lot of people with diarrhea, and potentially there was fecal transmission as well. It's not as prominent with this particular coronavirus, but certainly in the past it has been. And again, this is just to show you that among the patients, there were more people who had shock, right, among people in the ICU, which is not surprising. And just to point out that when people die from COVID-19, is that they're more likely to die from the usual things that happens to people in the ICU, which is they get shocked, they have cardiac arrest and acute renal failure, so multi-system organ failure. So it is really hard to get anything out of this because everybody got antiviral. Just about everyone received antiviral treatment. Again, they were using Calitra. The other thing that they were using is, they were also giving a lot of Tamiflu or also Tamivir, and at least a lot of patients also got antibiotics as well. So it's really hard to say what worked in this series of patients. I just wanted to just point out, while again we see this a lot in other viral illnesses as well, but lymphopenia was something that they observed. Now again, this is admitted patients, so and there was really no difference between people who are admitted to the ICU or non-ICU. Well, little, but again, with it was statistically significant. That was difference. And then this is also non-specific, right? So they actually show that there was an increase in the LDH, which from a clinician, an ID physician, we saw this a lot with people with AIDS when they had PCP. There was an elevated LDH. But in people who were in the ICU, they had higher levels of LDH, but that just shows lung damage, right? And then procalcitonin, again, which is a very non-specific finding, right? You see this with people who are infected, but certainly it was higher in people who were admitted to the ICU than non-ICU. This is just to show you, again, to remind everybody, again, the majority of mortality was associated with age. And again, I think Florian already showed this, but there were 416 people out of 44,000, more than 44,000 confirmed cases who were in the pediatric age, right? So 0 to 9, again, none of them died. And then among the teenagers, there was one patient who died. But again, it's a disease that affects more older patients. Now, this is just a postulation, but certainly the higher, while I think I agree, men is a weaker sex probably, but the thing about China is that 50% of men smoke cigarettes. So I think more likely that they have lung disease, while only 3% of women do. And so I think that might explain the reason why you have an increase. You have a higher mortality rate for men. And then the last thing, again, just to point out to everybody, that 81%, right, had mild disease, meaning probably didn't even need to be admitted at all into the hospital. This is just to show you the progression of one person who actually recovered. So you see that there are some infiltrates here and up here, and again, it's consistent when they did the CT scan. And then 24 days later, there was resolution. So this is someone who actually had symptoms, but recovered completely. Just a talk about hospital transmission. I think people are worried with this novel coronavirus because of the history with SARS, CoV in 2003. A lot of healthcare workers actually died and were infected. So it is a concern for me, being in infection prevention. But again, this is in the backdrop that there were no, they didn't know they had an outbreak at hand, but certainly it is, people are very infectious. If they're sick enough to be admitted, then potentially they are more infectious. And again, 41% were presumed to be infected in the hospital. 17 were patients who were hospitalized for other reasons, 7 for surgery, 5 for internal medicine wards, and 5 for into the oncology wards. And then 40% were healthcare workers. And the interesting thing is that one of the confirmed cases of COVID-19 was actually presented with abdominal pain. That was his presenting symptom. And so he was admitted to the surgical unit. And because they have a different mindset, they ended up 10 healthcare workers were infected, and then 4 others in the same unit, 4 other patients were then subsequently infected as well and became a case, were confirmed to have coronavirus. Again, just to show you that at least among the confirmed cases anyway, while there was a steady increase in the blue bars here are representing as confirmed cases among healthcare workers, at least by February 10th, it was starting to come down, because at that point, they were implementing infection prevention practices that were recommended by their CDC. How is, at least theoretically based on other coronaviruses anyway, I think we still need to learn a lot from this, is how is it spread? Well, theoretically, at least it's majority is person to person. And the CDC says within 6 feet, right, where respiratory droplets then are produced when someone coughs or sneezes. There is also potential for contamination of surfaces. So if someone sneezes and coughs or has oral secretion, their oral secretions, they touch a surface, and an uninfected person comes and then gets contaminated, and they also touch the mucous membrane, that's a way to get infected. I put a question mark on fecal contamination because, again, while it's not as prominent here, there is data to show that there is virus in both urine and stool, but it's not a prominent way of transmission currently. But with SARS in 2003, there was a huge outbreak related to fecal transmission. And typically, as with most respiratory viruses, and again, this is also speculation, that people are probably more contagious when they're most symptomatic, meaning if they're in the ICU on the ventilator with respiratory failure, they probably may shed more virus. But mind you, majority of people, there's still a larger set of the infected population who may not be that contagious, but there's so many of them, that's why it's spreading as well. So, and this is just to show you that the patient 1 from Washington State, that the CDC actually collected stool samples on this patient. Day 6 and 7, he reported diarrhea, and just to show you that he did have positive, the PCR was positive from the stool, but they only collected it on 1 day. This has caused a lot of consternation when this actually came out, but I wanted to just point out to you, patient 5 here was, so the whole family actually went to visit relatives in Wuhan. What I didn't show is are the relatives in Wuhan, but when they came back to Shenzhen, is that the patient 5 here is a 7-year-old boy who never had symptoms, but they actually did swab his throat and also collected induced sputum from him, and he did have positive PCR, even though he was completely asymptomatic. They also did a CT scan, which actually was positive, right, for findings consistent with COVID-19, or at least there was some findings. So it just goes to show you that asymptomatic shedding of the virus is possible. Now the question is, how much of it is contributing to infection? We don't really know, right? If you're not coughing, you're not sneezing, potentially, yes, your saliva will have virus, or your stool could have virus, so you could be contagious, but how contagious are you compared to someone who has symptoms? So again, I don't really, while people worry about that, I think we should worry about people who have symptoms more. The other one was, again, this is presumed, right? Because again, I'm showing you, this was reported to a case report, or at least a letter sent to JAMA, where they showed patient 1 visited Wuhan and went back to her hometown, and she then was exposed, or her relatives were exposed to her, 5 other relatives. And eventually she never developed any symptoms. And her relatives then developed symptoms and also had CT findings consistent with COVID-19. The problem I have with this is that her first PCR was actually negative. So was she really a carrier at that time? But she was asymptomatic, and then later on became positive. Now, the authors postulated that it could have been false negative, but you could also make a case that this relative here, because she started having symptoms, actually infected her, right? Hence, she had a positive PCR later. So we're not really sure about that. But again, so what is the best advice I can give you? Well, if you are diagnosed with coronavirus, with the novel coronavirus infection, just like any other viral illness, right, like the flu, you should stay at home except to get medical care, right? Separate yourself from other people in your home, right? If you have a separate bedroom, stay in that bedroom. If you have a separate bathroom, use a separate bathroom, right? But if you don't have a separate bathroom, as the person infected yourself, you should then wipe down every surface. If you go to the kitchen, wipe down every surface that you touch, right? That would help you from infecting your loved ones or your roommates. If you need medical care, call ahead before visiting your doctor, right? Wear a face mask if you're out in public, or if someone who is uninfected is within 6 feet of you, right? The face mask is really for people who are infected or for healthcare workers who are taking care of infected patients. Cover your coughs and sneeze, right? So cough into your elbow. Wash your hands constantly with soap and water for at least 20 seconds. Hand sanitizer, I always have it in my pocket if I don't have access to soap and water. Avoid sharing household items, monitor your symptoms, and avoid contact with pets and other animals. This is from recommendations from the CDC, right? In the last few slides that I have, I'll just run through some things that we have done here at Mount Sinai, okay? We have actually been having frequent communications with faculty, staff, and the whole Mount Sinai community with broadcast emails. We have trained our healthcare workers to identify, isolate, and inform, meaning that we will ask about symptoms of travel and exposure to other patients with or other people with potential COVID-19 infection. If they say yes, or if they screen positive, we put a mask on them and we isolate them into a room, either a negative pressure room, if that's not available, into a private room. Then they call infection prevention and our public health officials to get instructions what to do next. We try to shore up recommended PPE as much as possible, but the problem is majority of our supply chain comes from China, and there's nothing coming out of China until March 10th, I was told. So, but we're able to stockpile some PPE that we would need. We also provided refresher training for our frontline staff. The PPE recommended by the CDC are PPE, or personal protective equipment, that we are actually familiar with. These are things that we normally use, except for the face shield. But again, airborne precaution, which is an N95 mask, which we don't recommend for anyone to wear unless you've been fit tested, right? And if you do have a beard, you're going to have to shave your beard off to be able to fit test, right, properly. Gowns, which is just the isolation gowns, and then gloves, of course, and standard precautions. So meaning you, just like any other patient, you assume that they have something infectious, but the additional is eye protection. And this is based on data from SARS that a lot of healthcare workers got infected, especially if we're doing aerosol generating procedures such as sputum induction, intubation, all those actions that then sometimes their eyes actually got exposed. So your eyes are a mucous membrane as well. And so having a face shield that covers their face will help protect our healthcare workers from getting infected. Other related issues, we're going to try to put them in negative pressure room because that is what the CDC recommends until we know more. But again, if we do have a pandemic, we have plans to cohort patients, and we may not have enough negative pressure rooms for those patients. We were at least the first, we're going to try to dedicate reusable equipment, right? Again, we're cohorting. We will then that will be fine as well. Avoid procedures outside a patient's room. It's really hard to send a patient to get a CT scan because potentially they're infectious and they're really sick. They might be shedding a lot of virus. So we're going to try to do as many procedures in their room. Limit the number of healthcare workers involved. Right at this time, we're asking trainees and students that at least they should not be exposed if we can help it, right? But if it becomes a pandemic, potentially we will then give them on just-in-time training as well for the PPE. Restrict visitors, right? This is really tough. It's hard to tell visitors when they have a sick loved one not to come in, but certainly we're going to have some messaging about if you are sick, you shouldn't come in. And then in the first few cases that we have, it's really important that we observe our healthcare workers as they dock, right? So as they're taking off their PPE, we want to make sure that they don't contaminate themselves. And so we're at least going to have some coaches or at least some other healthcare workers watch them dock until they get the hang of it. And then we're doing some extra things to terminally clean the room and the patient gets discharged. Two things that's really important, right? The CDC was very helpful in this, is to say, if you're a healthcare worker or anybody, and if you just walk past a confirmed case of COVID-19, that is considered zero risk, meaning we don't have to track you, we don't have to monitor you, right? And then the other thing, if you're a frontline worker and you're registering a patient, if they come and register and they have symptoms, you give them a mask, you put on a mask on them, and you isolate them right away, that is also considered a zero risk. The only time a registration associate can become a higher risk or a medium risk is if a patient who had COVID-19 coughed on their face and they were unprotected, okay? Again, I think we already talked about this, and the same thing you would do for flu applies for COVID-19, right? And then I think my conclusions are probably okay, but we'll just talk about testing because I think that's important, that we have not been testing patients here in the US as much as we should. And even now, the recommended testing is anyone who has a fever or symptoms consistent with COVID-19 who had a known exposure, right? So you have to have been diagnosed and had a contact with someone who was diagnosed with it. And then if you actually travel to an endemic country or where there's transmission going on, you have to have fever and symptoms. So if you just had symptoms, we're not actually testing you if you went to Italy and coming back. There are some exceptions to the rule after discussing them with our public health officials, but again, we're not testing as much as we should. And then the third category, which I think we are learning from the case in New York, this case number 2 in New York, and also the case in Northern California, is that someone who comes in with severe pneumonia without a known epidemiological link, you should definitely consider to be tested for COVID-19. The good news about this is the state will release a little bit more liberal criteria for testing. So they're actually going to authorize more testing than just the current list that I just mentioned. And then we're also discussing and looking at ambulatory sites that will be designated testing sites as well, because our urgent cares and centers and our ER will never be able to handle the volume of testing if it does become more commonplace. So that's all I have. Thank you for your attention. Questions? Well,
I guess my question is for Florian. Florian, you said that they were doing clinical trials with lopinavir. Are they doing it purely for treatment, or are they also doing them for prevention? Because I haven't heard about them.
As far as I know right now, it's just treatment, and I think they're doing mild versus severe cases. I don't think they're doing it for prevention right now.
They should.
Well, it's a question of capacity in those cases, right?
Many people are asking about travel, canceling vacations. Any recommendations regarding that as far as flying, bus, train, and just canceling reservations altogether?
So, at least I can tell you what the Mount Sinai policy right now, right, is that if you have planned, or you're planning to leave to go to a country that's designated level 2 or level 3 by the CDC, you should cancel and not go, because that would be our policy. Now, if you were planning to travel to a country that's designated level 1 now, and while you're there it becomes a level 3, then potentially you will then be subject to quarantine for 14 days. So that's the reason why. So that's why we're saying that if you go, despite our advice not to go to a level 2 or 3, potentially you may have to use your vacation time when you come back, and you will be quarantined. Because the reason is, pretty much all our academic centers have said that if you have been to a level 2 or 3 country, you will be on self-monitoring at home for 14 days after you get back. So as far as planes and trains, it's very difficult, right? The planes are actually pretty good. If it's a modern plane, they actually filter the air. So unless you're really within 6 feet of somebody who has symptoms, you're probably okay. The CDC actually has a really good diagram of who they would contact if they found a case from someone who flew on the plane. So, but again, that's all conjecture, right? That's the best guess we have. We just don't know.
Yes, thank you so much for the update. So my question, I guess, is for both the speakers. Could you comment on the recent talks about the seasonality and transmission, like the case of people experiencing cold for the summer?
So, I mean, there's guesses, right? If you look at the human coronas, they are less prevalent during the summer, and they're more prevalent in fall and winter and spring. And SARS disappeared more or less during the summer. We don't know from the experience with SARS that was really because of the weather and the temperature and the humidity. So the short answer is we have no clue. The long answer is an educated guess from H1N1, from other pandemics, that probably there's less in summer. But if this really becomes pandemic, it will come back because there's always cold weather in winter, summer. There were cases there are still cases in places like Singapore where you have high humidity and high temperature. So I think we have to monitor what happens, but it's really not possible to conclude right now.
What do you know about the length that takes people to recover from pneumonia, pneumonia? You say that things take longer than usual. Most people stay in the hospital longer because they stay in the acid. So the same dialysis, PCR negative for 1 week. So we know anything about the length. How big that people take to recover from pneumonia? It is a normal amount of time.
So I don't think we know, but again, unfortunately, from our standpoint, they develop severe pneumonia, and it does take a while for those patients from even bacterial pneumonia, right? If they develop respiratory failure from a severe bacterial pneumonia, it takes them a while for them to recover as well. But I think I know to answer your second question as well. The CDC doesn't have any recommendations. How can you tell if someone's no longer infectious? That's the other thing, is that right now it's just saying call your public health officials. And that is the issue when we're using a PCR test as our diagnosis. We can't use that to clear patients to say that they're no longer infectious, because you could have just particles or DNA. And I think that's what happened in the San Antonio case recently, where the patient was positive, had 2 negative tests, and then the next one was positive again, and people thought she was still infected, but it could have just been she already recovered and no longer infectious, but no one knows, unfortunately.
That's also important for the burden to the hospital, right? Because
Yeah.
in the cases, on average, they need to stay hospitalized 1 week.
Right.
It's very different if they need to be hospitalized 4 weeks.
Well, that, and also infection prevention too, right? We're isolating them. We're wearing PPE. When is it safe to not have to wear the full PPE anymore if they're no longer contagious. So we actually don't know that answer. So
I have two questions. One is, anything known about the effect of this virus or SARS on pregnancy? The second question is, if Florian could mention a little bit more about the work that was done on the SARS vaccine.
Yeah, so the first question, there's only anecdotes about that. There was one severe case where a pregnant woman, I think in the second trimester, died, but then another, and that was celebrated by the Chinese media. A woman actually gave birth and she was infected, the baby got infected, but as far as I know, they're both doing fine. So there's no good data out there on that. In terms of the SARS vaccines, there was obviously a lot of work in animal models, but only 2 vaccines ever made it to the clinic. One was a Chinese vaccine that was based on an inactivated SARS virus, which actually gave very robust antibody titers in, I think, 60 vaccinees, and that was then discontinued. The second one was a DNA vaccine by the Vaccine Research Center, and that gave shaky neutralizing antibody titers, but that's all we have. It's a little bit further with MERS coronavirus because there was a recent push by CEPI to actually fund these studies, and so there are some in the clinic right now. So we have pretty good information about the vaccines and how to make them, but the problem again is that the pipelines are not established, the production capacity is not there. And even if Moderna would be able now to have a vaccine on the market, they would probably not be able to make many doses at the time.
So, do you know whether the diagnostic test or the medical bills will be covered for the non-insured?
Yeah, so I think there's a lot of discussion there, but I think for the most part, since the state's doing it right now, it's covered for the uninsured. Now, when academic medical center starts doing it, I think it's still because it's not approved necessarily, right? That it's that we're getting a waiver from the FDA. I don't even know if we can charge for that anyway. So.
All right, well, let's give a round of applause for our speakers. And they'll be up here if people want to come up and ask any further questions. Thank you so much.